Good morning, everybody. So until you guys start asking me to stop, I'll keep doing little healthcare terminology kind of things. And so as I've done the last several presentations that I've done, we'll cover a few terms really quickly. So does anybody know what that is in healthcare? What does that stand for? Nobody? Anybody? The Q stands for quality. No problem. Coming in. The A stands for adjusted. Okay. It's funny. Well, so I perfect. So most of the world uses this readily. In the United States, it's totally taboo, and Congress has actually tried to step in and stop this from being used in healthcare. So quality adjusted life years is kind of a term in healthcare where we try, as best we can, to provide some kind of a financial number as to what life is worth. And that's not very well accepted in the United States. We don't like to talk about this, and this is considered very taboo to say that somebody's life or months of life or something like that has a dollar amount that is justified and maybe a dollar amount that is not justified. We don't feel very comfortable with saying that this person's life is not worth this amount of money. And there's obviously a lot more into this, but this is, as you can try to control healthcare costs, if you're in a situation where there's a finite amount of money, which whether or not the United States wants to admit the fact that there is an actual finite number of dollars that exists to provide healthcare, if you actually put a number and say we have this much money to use, somehow you have to determine how you're going to differentiate when care is provided, what's worth the money and what maybe is not worth the money. Anyway, so this is, it's used in a lot of countries that have national health care where there are a certain amount of dollars available and they have to figure out how they're going to divvy out those dollars. Okay, so so this is usually a scale of 0 to 1. So 1 is going to be like a perfect year, total health, no illness, no morbidity, nothing like that, okay? So this is a little bit different, and I think this is an attempt to try to be a little bit more granular with it, but this is going to be disability adjusted life years. So this is going to look, because we all know that, if you get hit by a car and just, that's it, it's over, there's really not much more that goes into it. Or if you're, involved in some kind of accident or something happens really quickly and life ends, then that's one thing. But what about all of the things that we treat, chronic illness and stuff, where people live life and they're sick? They're not dying necessarily, but they're not whole, right? So this tries to take into account disability. And so this is a difficult topic, and this is something that everybody's going to have to kind of figure out as societies get larger and healthcare gets more and more expensive. So we all know the United States spends way more on healthcare per person than any other country, yet our outcomes aren't that different. In fact, we don't actually score very well in a lot of our outcomes data, and there's a lot of reasons that go into that. But this is kind of a big part of it. Most of the other countries have accepted the fact that there are things that can be done and there are things that can't be done. Whereas for the most part, we feel like everything and anything can be done. And so we haven't really put in a whole lot of thought into how we're going to stop paying for certain things. Okay, this is another term that's commonly lumped together with them, willingness to pay. And this, I don't know, this is kind of interesting. I mean, we all have, we all go to the store, we all see something, and there's a certain number that maybe we're willing to pay for something, and then a number where we're like, yeah, it's not worth it. So this is a little bit, it's not as simple as just what is somebody willing to pay for a certain intervention in healthcare. But this is, I would say, in a lot of situations, this is more of an ability to pay. And so think about certain countries, GDP, how much money is flowing through that country, there is a number as you go through where it's just not feasible. It's not feasible, to spend 3 times a country's GDP on healthcare. In most countries, especially in the developing world, if they spent the same amount of dollars per capita that we do, that would be their entire GDP, if not 2 or 3 times that. So that's what this is really kind of talking about, is what is a number that can still allow society to advance and take care of all of its other needs, but while providing health care to its citizens. And so this number is going to be different based on where you are and what kind of resources are around. And so there are different bodies that try to put a number on this, and this number changes. It's hard to find, it's hard to really get a clear answer as to what dollar amount is accepted. But in most of the more developed countries, it's going to be around $50,000 a year, $100,000 a year, but it's not going to be more than that. And in other countries, it's going to be dramatically less than that because, again, they just don't have the resources. And so one way to look at it is somebody has an illness that may be terminal, and we can spend X amount of dollars to prolong life 6 months. And you can look at that scenario and say, well, this is justified, or there should not be a dollar amount that can be placed on life. But if you think about it a little bit more practically and you say, well, with that same amount of money, how could we implement preventative care measures or take care of things that maybe aren't as severe for a much larger number of people, right? So if you're doing diabetic education and training and even medication or something like that, with that same amount of dollars, right, what's the impact that has on life, as opposed to maybe extending one person's life 6 months, you could extend 100,000 people's lives for 5 years apiece or something like that. And so obviously this isn't an easy situation, and these are things that most of the world are dealing with. And we kind of have to too, but it's just a lot more hush-hush and quiet. And we all know that there's a lot of money that floats around in healthcare. And I think first and foremost, it's being conscientious of that and realizing that there are actual finite levels and numbers that are available to us. So this is a big thing, and as you see studies, you'll see finance studies and things that are happening. It's not just about, I don't think we can really just think about how long does it extend life, or does this treatment do that, but you do kind of have to think about the costs that are associated with it. So more cost-effective care is just going to have to be part of our future because otherwise it's just not going to be sustainable. The United Kingdom is probably the most kind of understood, or at least a little bit more forthcoming with some of the numbers, although it's really hard to find like this is the number. But when they kind of distribute the dollar amounts that are available, there is going to be a number, right? And we all know that this does take place and this happens where if a treatment costs X amount of dollars and it's expected to increase survival or decrease symptoms or whatever, this amount, there is an algorithm that goes into this that determines whether or not that's going to be justified financially. And again, it's not so much withdrawing care from one person as it is you have to think about how those resources would be used to impact others. So no easy answers, but this is part of healthcare. It's part of our probably our future that we're going to have to kind of figure out. So yeah, I think it's a good thing to be aware of. And more studies are being published that include this as part of the write-up. So hopefully that kind of makes sense. Anybody have any thoughts on this? Any experiences or anything that makes them think about it?
It's me.
Yeah.
I was thinking about this. This is, in the UK, I mean, we're talking about nationalized healthcare, right, where the government's really responsible for all of those dollars, and they're taking at least a portion of that from tax base. And then in the United States, we have this this healthcare system that is dual, right, where the government is Medicare, Medicaid is driving one portion of that, where they'd be concerned here, and then we have these private insurance companies. And not to say that they're making millions, but they're making millions.
Yeah.
To try and, they're trying to act like the government and do that. Yet the problem they have is the subscribers who keep saying, no, I'm actually paying you to provide services. You can't necessarily put me in this block. And that's really where we find ourselves fighting the data that they're pulling from, nationalized healthcare and trying to apply it to their block. And we say, okay, that's fine, but it's not my tax dollars. I'm actually paying you, and I want these services. And we're pushing back and forth against this conversation, and and then they're still making lots of money. And so we see their profits. As a subscriber, I see their profits, and I say, okay, well, you're doing just fine. The CEO of United Healthcare was top pay. I forget what he made last year, but and you can't fault them. I mean, they have shareholders. Their job is to be they're an insurance business, but their business is to make money. So it's an interesting dance, and if we ever switch fully over to this type of healthcare system, we'll probably all have to start making investments.
Yeah. And if that were to happen, because that's what everybody says, right? If we just switch over, and there is, right? So instead of having CEOs of companies who are for profit and everything else, if everything was just altruistically managed, right, appropriately, that all the costs would be reduced, because you're not paying the $20 million salary to that CEO. And the $20 million is a lot of money, but in the grand scheme of healthcare, it is a very, very, very small blip, right? And so do we think that healthcare would get cheaper if there was not this private sector for-profit component? What do you think?
I think it may get less expensive, but the problem is each of these large healthcare companies also lobby they lobby not only constituents but Congress and Senate, right? So their job is to stay in business. Their job is not to move into something.
Correct. Yeah. No, there's a lot of interest to obviously keep this going.
There'd probably just be a lot of governmental that way. There'd probably be a lot of waste, as there is in every other government program, as I said.
Yeah. So waste is a concern, right? How's it going to be managed? Who knows what moral hazard is? The term moral hazard. What does that mean? Okay, and this has been pretty well understood, and there's plenty of data to support it. What happens if you have a group, and we saw this with Obamacare when it rolled out and everything, but if you have a group of patients, 50 million people who don't have insurance, what happens as soon as they get health insurance? Because that's the big argument, right, is that costs will go down because these uninsured people don't get care in a timely fashion and everything like that. But what happens as soon as they receive health care to their healthcare expenditures? Goes up, right? It's cheaper for them, and that's what everybody talks about, but their access to care becomes cheaper, but the actual burden of healthcare financially goes way up, right? And so if everybody now has no restrictions to access, the dollar amount actually goes up, which is why you have to implement this type of a thing. And I think we would have to get used to a very new norm, right? We're no longer paying a premium, paying for a membership into a health insurance that's then going to compensate us, or that's going to compensate for all the care that we want, not just need, but kind of want. And we're going to have to start being willing to let somebody else make the decisions that say you are worth this or no, you are not, right? That's not something I don't know if we're ready for, but everyone's asking for it, but I don't know if they really understand what they're asking for.
Who implements the dollar policy? Is this coming from doctors, or just oh, this surgery is going to be too much, so you're just going to die?
Yeah, so just like anything in, it's going to be the money, right? And in this scenario, who has control of all the money? The government does, right? So in the United States, it would be DHS that would have that, and of course CMS would morph into something like that. But in these countries, the health department is going to be the one that's going to set these numbers, and there will be exceptions. There will be the things in the middle of the road that will have to be reviewed, kind of on a case by case. But for the most part, the government is going to have control, and that's. In the United States, we're not very fond of that. We're, a lot of anti-government kind of, we don't trust the government to manage, much, and so the thought that they have control over this is not a very acceptable thing for a lot of people. But in other countries, it is quite different.
Well, your autonomy, in other words, you deal with it now with authorizations for different procedures, MRIs, surgeries, different things. It isn't the physician making the decision, it's some entity.
Correct.
Making it, the insurance company.
Correct.
And as he asked, well, who makes that decision? And you're going to have all of these multiple layers of people involved making the decision when it's taken away from the physician who knows what's best for the patient.
Yeah. Yeah, we really don't get to decide. We ask, right?
Yeah.
We get to implement, and we ask for what we would like to do, but we're at the mercy of everybody else to say, yes, this can be paid for, right? Because that's what it all comes down to. It's the money. And so if we're told that it won't be paid for, it doesn't really matter what I want and even what the patient wants. For the most part, it's going to come down to whether or not somebody agrees with the plan and is willing to pay the check. Okay?
One thing about the model that we have is it's all treatment-based, and very little, if any, of it is prevention.
Wellness prevention.
Wellness. I think that's one of the areas that there's value in what we do here by meeting, publishing educational content and things, because those things don't have a CPT code really that you can just go and bill for in a traditional sense. But there's with everybody on their cell phones and eating fast food and not being as active as we used to be, we're not going to treat our way out of this, no matter how much money you throw at it. So at some point there's going to be, or has to be, some sort of paradigm shift towards we have to be more focused on prevention than we are now.
Yeah, and that's exactly the point. And that's where we find ourselves, right? It's tough because the innovation and the advancements that take place in a system like ours is extremely good, right? That's the strength, right? We don't have as many limits. And so, and I do a lot of things that are kind of outside of what would be normal, and I push to get things paid for that aren't kind of mainstream, and we're pretty successful most of the time. But we get to see outcomes that otherwise, if you're looking at things like saying, well, there's no evidence for this, therefore we won't be paid for, end of story. The problem is if that's the stance, then you kind of wall yourself in, and it's harder to make progress, and it's harder to kind of push and advance the technology. But at the same time, that becomes our focus, and we are very much a treatment-based thing. And everybody says, well, how do we transition to preventative care, and how do we transition to outcomes data as opposed to I did this, therefore pay me that, regardless of what the outcomes are. And that's a really, really tough thing to do. But the only way you change physician behavior is by changing compensation. That's the only way that you can successfully. You can provide all this evidence and data, but the only thing that really quickly shifts how a physician practices is how you impact the money that comes into their own pocket. Because just like the CEO of United Healthcare or anything else, we are all, at the end of the day, still kind of concerned about our own situation. And so if there were CPT codes that we could bill for, these types of interventions, then you would see it tick up significantly. But it's really hard to measure outcomes, and it's really hard to provide value for outcomes, because then you have all the comorbidities that come in on the front end. I mean, it's a huge issue. It's a huge question. Yeah, if the outcome of this surgery is this, then changing compensation based on that is just a really hard thing to do, because there's so many factors that go into it. What is the patient walking into this scenario? Are they a relatively fit person that got hurt, living an active life? Or is it a chronic illness? They've got lots of different chronic things going on because they don't move and they don't take care of themselves and all these other things. The outcome of that intervention for each of those patients is going to be dramatically different, not because of what I do, right, but because of what they do. So that's kind of the $1 million question that we've all been multi-trillion dollar question that we're all trying to figure out. Is how do we provide assigned value and compensation based on an outcome as opposed to a procedure? And that's a really tough one. I've thought about this for 10 years as I've been studying this stuff and going to school for this stuff, and I don't know the answer to that. Nobody does, otherwise we'd have it in place. So just something I want you guys to be aware of. Think about these things that are happening. It's a little bit bigger picture, but we all function within this process.
I don't know if a lot of you are seeing the same thing, but I think society is getting to the point where they're really not trusting healthcare anymore. And I think I love what John said about like our focus on wellness. And I think eventually we got to take a point as healthcare providers where we need to focus on prevention and wellness and education. We're getting out in schools, and we're on social media more and educating society on how they can prevent a lot of these things, because I think people are looking more for that. When they're, I was just talking to a patient yesterday, and he was talking about his wife and his frustration with the medical system. He's like, we got a medication for her pain. It was opioids, and then she got constipation. She was admitted to the ER twice for constipation, and then they gave her medication to, decrease the constipation, and then she got nausea, and then she got a medication for the nausea, which it just led down this road. And he's like, I'm just sick of it. We're taking her off everything.
Mm-hmm.
And it's just decreasing their confidence in the medical system. I think we just eventually got to get to the point where we got to be on the front lines. We got to be in the elementary schools educating. We got to be in the high schools educating. And it's going to take a huge shift from all of us to be able to do that.
Yeah, very reactionary, like John said.
Yeah, I completely agree with that, and I've thought for quite a while now that we regain the trust by focusing on longevity and wellness and prevention as a community, and have that be our outward educational piece. And then, as many of you know, we've been working with the chiropractic profession for some time to try to develop a program in that profession that is outcomes-based spine management, and it's not funded in the traditional insurance mechanism, because I think it's going to have to take something outside of the traditional paradigm to disrupt it. And if you come and say, well, we've got all these people that know how to manage musculoskeletal care and have it driven by the outcome, then that will, I think, be one solution to this in our discipline.
Yep. That's a huge question. We've been struggling with this for decades.
One problem in our country is that we have like $5 trillion in allotted money, and about 66% of that's a waste. And 33% is probably a real true waste, but 33% of that's going to be tied to mutual funds and other investment companies that we are all part of. So we want costs to come down a little bit, we want our portfolio to go up.
Yeah.
So there's that disconnect.
Yeah.
And how to get through that, I don't know. But
Yeah.
it's just because I know some companies say we actually don't want to decrease costs here. We could save you money here, but that's not the goal. Because it might hurt something over here on their other investments. So they don't mind spending the money and wasting money. So there's going to be.
Yeah, the interest alignment is our problem, right? So if I do a surgery at a hospital, and I can say, well, I can do it this way, and it will be a lot cheaper for the patient, right? Maybe it's 2 surgeries, or kind of one surgery that does all of this all at once. Whereas insurance won't allow us to do that. And they say, well, you have to split it up. You'd have to do this surgery and then later do that surgery. It doesn't make dollars and cents. And you think the hospital, right? Well, the hospital's not advocating for that either, because guess what? They make more money if you do more surgeries, even if you accomplish the same thing in more surgical sessions, then that's better for them. And you say, well, yeah, but there's an increased risk of infection and complication. Well, guess what? If it comes back infected and you have to do another procedure, the hospital makes more money, you know? And so it's like everything's set up to perpetuate this process and this problem. And there's really not a lot of incentive financially for us to actually get these costs down, because every time the dollars flow out, somebody is benefiting. And if we get better at doing certain things, then those dollars are going to be less for those people. You know, and that's why there's just so much inertia that keeps pushing this process. This is a really hard thing to change because we are talking trillions of dollars, and so it's tough.
I read an article from Mark Cuban yesterday, and he has a company called, I think it's Cost Plus. They're trying to break that model of pharmaceuticals and the middlemen. They're trying to take out the middlemen. So it really brought up just some thoughts on the number 2 cost on an employer's balance sheet, second to their salaries, is healthcare. And I think that's where the squeeze is going to come too, and that's where a lot of the pressure is going to come on businesses. And they're talking about having to have a corporate level or a C-level position that's over healthcare just because of the amount of cost that is associated with it. So I think there's going to be some inertia coming from businesses wanting to manage it because it's shifting onto them.
Yeah, it's a big cost. You know, you see this with Walmart and Google and Amazon, right? Kind of creating their own healthcare companies. Okay.
Dr. Anderson, I have a question about something in theory. If we have a population of really chronically ill patients, and we tell them that, you know, there's simply no money for treating them because we're withholding it for altruistic purposes for preventative health, and then we have a group of patients that are told that, you know, essentially they're going to die, I imagine that their families would not have trust in the healthcare system. Do you anticipate that that would make it difficult to even use that money to implement preventative health measures?
Yeah, so obviously the expectations, right? And that's a big difference. In the United States, everybody expects everything and they expect it right now. And they really aren't okay with anything else, right? There's plenty of patients that don't want to wait 3 weeks to be seen by a physician. But yet if you experience some of these other systems, not only, I mean, that obviously happens, right? So I was in Canada and the lady that was hosting this had really bad carpal tunnel. I mean, it was like, she was struggling because of the carpal tunnel. It had been diagnosed, everyone knew about it. She was referred to neurology about 18 months prior and was still waiting for that appointment. And then she, of course, would then need to get in to see a surgeon. And she was somewhat frustrated by it, but she's like, this is how it is, right? And so expectations would definitely have to change, right? This certainly couldn't be just done overnight without a pretty cataclysmic kind of shift in expectation and ideology, right? And this requires a viewpoint that's not me. This requires a viewpoint that's a little bit bigger, right? What's better for us as opposed to what's best for me. And that's why I think, you know, when all the people who really want to push for this system, I don't think are the ones that are probably actually going to be the most accepting of the requirements that are going to come along with it. And so, yeah, there's going to be a lot of growing pains. There's going to be a lot of pain that comes along with that. But that's an excellent point.
So last night, this was the scenario. The ER called 82-year-old that had an altered mental status, and her family was told to go to the Mountain Point ER, but they heard Mountain View. So they're in Payson they're down in Payson at this point. The ER doctor's calling me. So he has no history. He has no idea of what her baseline is, no idea what the goals are. And they did a CT scan and noticed a couple of red blood cells in the subarachnoid space, so she has subarachnoid hemorrhage. And he doesn't know if she's anticoagulated. And so he's in this situation of throwing a bunch of tests at her, wanting to treat potentially with reversal agents that are very expensive. And that's what an ER doctor is supposed to do, right? And so I was reflecting on that scenario, and I told him, I'm like, the amount of subarachnoid hemorrhage on this is trivial. And she has a bunch of other comorbidities that are probably, she had a mild heart attack in the context of this, and she also had an acute kidney injury, and she had possible pancreatitis, and she had some elevated liver enzymes. And so here he is in the ER, running all these tests, considering all this treatment, and I think that our healthcare system is stuck in this conundrum all the time. How much do we do? How much do we treat? The physician or provider is worried about the risk of what they're doing. Somebody's going to come and look at this situation, and well, I didn't give them this, therefore you're negligent in your care. And so I think it's a really important thing to contemplate. Not an easy solution for sure, but
Yeah.
all the time.
Yeah, risk. I mean, we all know in the United States more than anywhere else, litigation concerns drives a huge amount of cost. I'm glad you answered that call because I was on call at Mountain View last night. So.
The patient was at Mountain Point. The family.
Oh, was it Mountain View? Okay, well, that's good.
We had no ability to do anything but just treat the skin.
Yeah. Yeah, and that happens all the time. And sometimes, they will have undergone the same workup 3 hospitals over, but we can't get access to the imaging, right, in a timely fashion. They had labs done 6 hours ago, but we're doing them again, right? And we're getting a rescan because we got to figure out what's going on. We can't just let this person die. So there's a huge amount of waste, for sure, that goes into the care that we provide. So just something to think about.
I was going to say, I think that's kind of a massive testament to just kind of interpersonal communication as well. Being able to shoot a text across or being able to call somebody I think there's so much, holistic gain in that, because now we can see your perspective and my perspective and come together on much more of a holistic.
Yeah. Yeah, the teamwork definitely makes a huge difference. It cuts down on a lot of that. But we're not very good at that, right? We're not very good at that. All right, so really quickly, I wanted to at least talk about mentoring a little bit. The farther we get out, the farther I get out from training and stuff, when you're going through it, you're kind of bottled up inside of it and everything. And I kind of thought I'd never care if I ever sat through another, Grand Rounds, M&M, all the stuff that just you get inundated with training and stuff. But as you get out there, you realize the real value in it, right? Of having these conversations with other smart, like-minded people, and you see why it's a good thing. So just briefly, what's the value of being a mentor? Why do we do this? Who in this room hasn't been impacted by somebody, right, that helped them along their way, that they were a mentor, that was a mentor for them? Chances are you probably had a lot of them. And so does it need to be formal and well organized, or what about informal mentoring? Do you think it matters? I kind of don't. I kind of am an informal person, so I like informal mentoring. I think nothing ruins, I want to say ruins, but I just don't think there's this, value when there's a form and it's like discuss these things. I understand why it's there, but I think the real life approach is a little bit more practical. I like to be able to just be realistic and let people know and teach with, what's real. What do I actually deal with every single day? So I like the informal approach. And then the relationships. So this is pretty big, within neurosurgery, it's kind of a smaller world. So one of my mentors, Bob Harbaugh, was my chairman at Penn State, and he trained under Yasser Gill, right? He's one of the fathers of neurosurgery. And so there's almost like a pedigree or a lineage that comes down through this. And it kind of connects our profession over time, top to bottom, but also side to side, right? Other people that came through a similar process. And so this is going to exist in healthcare, and pretty much all of us, whether no matter what we're doing, right? Everyone in this room has gone through this process, and it's hard. People will ask me things and be like, how do you know this, or how did you come across this? And it's hard, and I always say it's hard for me to remember what it was like to not know neurosurgery. And I remember sitting as a med student with Kim Burchill, who's at Oregon, and him saying that to me, and I thought, well, that's kind of weird. Like, what do you mean you can't remember what it was like to be in this, going through this process? But it definitely happens, right? It just becomes part of every bit of our life. And it's hard to remember what it's like to not know these things and go back in time. But everybody goes through this process just like we did. So what are the benefits to the mentor? So everyone in here probably has been a mentor in some way. What are the values that you've seen from being a mentor and having somebody learn from you.
Sometimes it can remind you of things that you were really excited about before and kind of drifted off, but then because someone else is really excited about that topic or that area, then it rebuilds your excitement.
Yeah, I like that, right? But you get jaded. We get jaded in this world. We're worrying about insurance companies letting us do things, and we get bogged down in the frustration of it. And sometimes we forget the part of medicine that really gets us excited and provides that value. And we see that in younger people who haven't been jaded by the same system, right?
I was going to say, I think it stops you from just going through emotions. Because you're constantly thinking about how you're going to explain what's going on and what the procedure is, and you're getting much more deep into the thought process of it instead of just rolling through it.
Keeps you honest, right? That's what I say all the time too, keeps you honest. And sometimes I'll have students or somebody and they'll ask me something like, why do you do this? And I'll tell them, and I'll say, have you not seen that or something? They'll say, I did, and I asked, and they said, I don't know. And I just thought, man, if you can't say why you're doing something, then that's a big problem, right? I mean, that's a big mistake, right? So you have to know why you're doing everything.
For me, lately it's been the business side that I've been wrestling with. I mean, I went into healthcare to do healthcare. It's a hard dance of learning healthcare and then trying to do business, and it almost feels like you give up on yourself when you're going to the business side, and then it's just that. But then you go meet with someone that is business side, and they're not to destroy people's lives and take all the money. It's good to have perspectives from other people and how to manage to work with those different, I guess, emotions. I think mentors help more with emotions than anything.
Yeah.
You're up against fears, you're up against challenges.
Yeah. Yeah, I think one of the benefits is, and it keeps you up to date, right? Keeps you relevant, keeps your medical education up to date, because things change. That always drove me crazy as a mentee when you had these people who've been neurosurgeons forever, and you'd be like, man, this is so outdated, right? There's been 17 studies that have shown that this doesn't provide better outcomes. And it's hard to keep up. We're bogged down in it all day, every day. It's hard to keep up with the latest science. Okay, and so the benefits of the mentee. So we don't have time, but again, everybody goes through this process, and so they've got to go through this process too. It helps them develop their own voice. I think that's a big part of it. They get to teach. They will educate us, right? They educate the mentor all the time. They've got to learn skills, and they're going to bring a lot to the table, develop relationships. Part of the legacy, again, like I mentioned, they're going to go out there and do the exact same thing for the next generation. And they've got all of this knowledge, and they spent all this time learning all of these amazing things, and they need to be given an opportunity to actually put it into use. A little bit of trial and error, but with that oversight. I was just talking to one of my mentees. He was a med student when I was a resident out in Pennsylvania, and he's just finishing his chief year, and he's going to start his fellowship down at Emory, and he's asking about jobs and all of these different things. He reached out to me because he wanted to ask my opinion on positions and different things that he had in front of him, and that's I think that's an amazing thing. I think that's probably one of the best things I get to do anymore, is to help set the stage for somebody who's coming up behind me, be able to help provide them with a little bit of guidance, because it has a huge impact on them, and then in turn it's going to have a huge impact on so many others as they kind of enter their own world. And advice-wise, he said anything that you would really emphasize, and I just said, when you come out from being a resident, even though you're doing a lot of things on your own as a chief, you always have that person standing behind you. But that day, even when you're doing kind of a pretty simple case, that first couple of months when you realize that there is nobody standing behind you, right? And when something happens, anything happens in the room, you're going to look around and everyone is going to be looking at you. And so, they have to be prepared for that. And I think that's what I'm the most grateful for, the misery of my own training, sure, but walking out of there and actually going through that process and feeling good, knowing that, looking around and having no one behind me, but feeling pretty darn good about it, made me so much more grateful for the mentors that I had. as I went through that process. So I think this is an important thing. We usually have some students around, and so whenever you have the opportunity or the chance, take advantage of it. It's good for both of us. It's good for them, and it's great for us.
I like what you said when you said get somebody to call you back. You know, for us with the students that we take and even the therapists that we mentor, as they exit, I'm always saying, like, look, you're part of who we are now.
Mm-hmm.
Don't lose my cell phone number, and if you have any questions, I want you to call me. We try to keep that relationship moving so that if there is, you know, if there is a question or something, and we're talking to a therapist, they were in a different environment, saying, like, I just don't feel like I got I wasn't able to get my questions answered.
Yeah.
My first question to this individual was like, did you lose my phone number? Like,
yeah.
What happened?
Yeah.
You know, we want to still be able to be there for you, and we take this real seriously.
Yeah, we're all connected. And I think that's how you know it went the way it was supposed to, right? When 5 or 6 years later, they reach out, right, and say, hey, you were talking about this once. This is the situation I'm in. What would you recommend, or what are your thoughts, right? And that's how it should be, because we are all connected. It's easy to forget that. Okay, well, thanks. Thanks for staying a little late, getting into the weeds.